Again, like to thank Dr. Ganesh, Sudeep and Krishna for inviting me. So, this is on preconception planning in patients with diabetes and thyroid dysfunction. So, I'll cover first diabetes and then go on to the hypo and hyperthyroidism. So, pre-existing pregnancy, as you are aware, is associated with increased maternal and fetal complications, and optimized preconception care can improve outcomes. So, this is one data to show that if you have a good optimized preconception care, you can have a reduction of congenital malformations by 71% and A1C, a pregnancy A1C by around 1.27% and preterm deliveries by around 15%. So, before any lady with pre-pregnancy diabetes, that means type 2 diabetes or type 1 diabetes, plans pregnancy, you need to have some sort of a risk stratification. A very broad data includes that people with chronic kidney disease, cardiovascular disease, especially of very recent origin, heart failure or chronic liver disease carries a very high risk of problems arising during pregnancy, and these people should be really counseled whether they should go in for pregnancy, whether sometimes because the maternal mortality risk will outweigh any successful pregnancy outcomes. Now, regarding the reproductive timelines, it is recommended that now any lady of reproductive age who is not using a permanent contraception should have some discussion about pregnancy when they are planning, if they are planning, and then that intermittent time between your patient's visit and pregnancy should be the time that you take to optimize metabolic control, weight and management of risk factors, and consider using contraception till a planned pregnancy is there. Now, regarding the timing of pregnancy planning, during that intermittent time you can consider addressing the PC if she's got irregular periods, looking at ovulation, risk of PCOD. Try to achieve A1Cs of less than 6.5% prior to pregnancy, and if you have anything more than 10%, advise strongly against pregnancy till you reach the targets. Discuss weight related adverse effects on pregnancy outcomes, and modify the pharmacotherapy prior to pregnancy, and modify whatever other risk factors that the lady has got. So, in general, metformin, I will come to more details of this. Metformin can be continued as an adjunct to insulin in pregnancy. For CV renal benefits, consider continuing SGLT inhibitor GLP-1 RA till a decision of pregnancy is made, because some of these patients are very essential that they continue these drugs. So, only when a decision is made that you need to withdraw the drugs. Insulin is always preferred in pregnancy. Consider switching on to insulin. Make the patient understand about hypoglycemia. Train the patients about self-monitored blood glucose and CGMS, because some of the time we see that only when they get pregnant they start doing their first SMBGs, which may turn out to be more difficult for them. Now, coming to weight management prior to planned pregnancy, there is very strong data that maternal obesity is associated with large for gestational age babies, increased gestational diabetes, gestational hypertension and obesity in newborn and during childhood. There are data like the pre-babe pilot study which showed that if you have a partial meal replacement based weight loss, you improve fertility in women, and those with a BMI of more than 30 advise 5 to 10% loss prior to conception. A 500 to 850 calorie deficit diet is recommended. Consider using anti-obesity medicines with clear instruction to discontinue it when they really plan pregnancy. Now, these are one data to just show you the outcomes of pregnancy. That means at least a 10% difference in pre-pregnancy BMI can lead to almost a 10% reduction in preeclampsia, gestational diabetes, indicated preterm delivery, microsomia and stillbirth. So, this is very important, because when these women come to you many years or prior to going for an infertility treatment, you should discuss with them regarding weight loss prior to a plan, because most of them are in urgency to start some fertility related medicine. So, taking a time of like 5 to 6 months to plan weight loss would be a good idea for them. Now, coming to contraception, I will not go into the details of this. Folic acid definitely should be started 5 milligram 3 months, at least 3 months prior to conception. Now, coming to more details of glycemic control. So, I will just start here with a case. So, this is a 36-year-old lady with type 2 diabetes of 6 years on metformin, glycoside and dapagliflozin. She arrives at 6 weeks of gestation and A1C is 7.2. She's got normal CV, renal and retina. What will you do? Will you inform the patient that dapagliflozin and glucoside are not safe during pregnancy and you consider a medical termination of pregnancy? Or will you inform that the A1Cs are 7.2%, there is a high risk of congenital malformation and consider MTP? Or will you start her on a basal bolus insulin, explain the risk associated with high A1C and OAD? Now, one is to understand, I am not going to answer the question now, but just to take you through this, preconception care and early pregnancy care is actually a continuum. They are not two separate things. It moves from one to the other. And pharmacological therapies during preconception should be tailored to sort of ensure safety in early gestation. And it has been seen that people who have been exposed to SGLT inhibitors, DPP4 inhibitors or GLP-1 RAs, these are not studied in pregnancy, but if there have been an accident exposure to these drugs, there are no major adverse effects also reported in pregnancy. So that basically means that if someone has accidentally conceived on these drugs, there is no urgency to go for a medical termination of pregnancy as and when. We really don't know what is going to happen, but generally if there is an exposure, the aim is to stop the exposure, start insulin and get the glucose under control. So this is some data to look at how A1C and congenital malformations are related. You could see that the risk generally increases above an A1C of around 6.5%, and once it crosses 7%, there is a dramatic increase in risk with very high risk above an A1C of 10%, showing that even if your patient conceives, it's ideally good for patients to conceive at an A1C of less than 6.5%, but just because someone has conceived at 7% does not mean that you should be fear mongering the patient in terms of going for a, you need to really explain what we know in terms of science and then take a very informed decision on how to go ahead. Now, which insulin and which insulin regimes to use? Basically, most of us would prefer a basal bolus regime as the preferred mode. You can use a regular or an analog, short-acting analog or an ultra-short-acting analogs, and you can consider using a long-acting or an intermediate-acting insulin, like intermediate-acting like NPH or a long-acting like detemir, digludec or glargine, especially if glargine has been used earlier. But it's not a hard and fast rule. There are patients who get pregnant on premixed insulin. There are doctors who start people on premixed insulin and get good control. There are some patients who can be managed with one basal insulin and one short-acting analog. So different combinations can be tried as long as the patient is well controlled. So the glucose targets are there, which has been proposed. One is very important thing is to teach these patients how to do SMBG. Let them get that confidence. Consider doing a continuous glucose monitoring if your patient is happy to afford that. Look at fasting glucose, try to maintain reasonably good controls as you would do in any type 1 or type 2 patient. This is the sort of guidelines which are recommended: 108 fasting, 1 hour 153 and 2 hour 135 and an A1C of 6.5. But remember that the pregnancy targets are much more stricter. Most of the time in our OPDs, we tell them the pregnancy targets and try to achieve the pregnancy targets even in the pre-pregnancy time, so that they are not confused as they move in from preconception to conception. This is some amount of CGM data is now evolving in type 1 diabetes, and this is a sort of data. I am not going into too much of detail, but there is some information to support the use of continuous glucose monitoring in people with type 1 diabetes in pregnancy. And there are some changes in terms of the ranges that is used. The range is 63 to 140, unlike the typical CGM where we keep at 70 to 180. That range has to be changed. And there are ranges for time below range and time above range. Now, regarding type 1 diabetes in pregnancy, my strong suggestion is that if you have an endocrinologist in town, I think you should consider referring type 1 diabetes in pregnancy to them for preconception care, because it is a very tough time to intensify their glycemic control without undue risk of hypoglycemia. Analogs, short-acting and long-acting analogs, a welcome addition, at least during the time when the lady gets pregnant, because I know the cost of therapy. Enhance again monitoring and improve the skills of SMPG. Meal management, again entire area by itself. Most of the time our dietitians take care of that. There's reasonably good data on the use of insulin pumps in pregnancy, especially the new one, the artificial hybrid closed loop pumps in pregnancy. This is one recent data of Medtronic in an RCT of 95 patients where Overall, there was not an improvement in TIR, but overall improvement in night time below range, improve overnight time in range and higher treatment satisfaction. The ADA recommendation says that automated insulin delivery devices with pregnancy specific glucose targets are recommended for pregnant women with type 1 diabetes. Now coming to diabetes complications and their implications in pregnancy. So I am just showing you 3 cases. Which of these individuals can be considered at high risk for planning pregnancy? One is a 32-year-old with type 1 diabetes, A1C of 11%. Second is a 30-year-old with type 2, BMI of 28, hypertension, EGFR is 48 and UACR is 420. And the third one is a 36-year-old type 2, BMI of 26, dyslipidemia, hypertension, cardiac stress test positive during evaluation. So in fact, all 3 of them are at high risk, and although there is a risk gradation between them, you can consider the one which is the third one will probably be the highest risk, but everyone is at risk. Now, what happens to diabetes complications and what are their implications? Always, especially in type 1 diabetes, if the patient has been on a long duration of type 1 diabetes and even type 2 diabetes, screen for retinopathy in pre-pregnancy, treat with laser and anti-VEGF if it is indicated, wait till the patient achieves good control, wait till the eye is totally stable before planning pregnancy, and explain always, even if the eye is stable, always explain that there can be a risk of worsening in pregnancy and you should be screening in every trimester or depending on the risk more frequently. Diabetic kidney disease again is associated with multiple increased bad outcomes like hypertension, SGAs, neonatal ICU admissions, pregnancy loss, etc. Pre-pregnancy again screen. If you have a UACR of more than 300 or a CKD 4 or 5, you are at very high risk during pregnancy. Again, what you can do is to optimize the blood pressure prior to pregnancy, have a multidisciplinary discussion with the nephrologist and the gynecologist regarding the real risk which is there, the things we know and things we don't know in pregnancy, what can happen, and always very aggressively follow up the patient in pregnancy. There are no very strong guidelines as such in this area, because if you look at the overall number of patients who have been going through this, it's very small, but always counsel the patients. Now, you need to have a medicine checklist in the preconception to ask the patient what all medicines the patients are taking, because most of the time the patient will be moving from the physician to the endocrinologist to the cardiologist to the nephrologist. Go through the entire list, see which all medicines needs to be changed. In fact, most of the medicines except metformin that we use needs to be either modified or changed. Amlodipine generally is considered safe as an antihypertensive, but nifedipine or other medicines are generally preferred. So a list, you should go through the list and make sure that the patient is not on any of this. So here ends the diabetes. The thyroid part is, I'll go through the thyroid part very quickly. So preconception care in people first with hypothyroidism. So this is a 28-year-old lady, already known to have hypothyroidism 6 years back, presented at 8 weeks of gestation. TSH is 8.3, T3 and free T4 you can see. Thyroxine, she is already on 100 microgram. Questions are, what is the target for treatment prior to pregnancy? What are the treatment targets in pregnancy? Is there any point in doing an anti-TPO antibody for her? So pregnancy and hypothyroidism, again I am not going into too much details except to tell you that it is very important that hypothyroidism be addressed prior to pregnancy before the patient becomes pregnant, when the lady becomes pregnant. It is strongly associated with the neurological development of fetus, and the most important point is that most of the time the person presents to you after certain weeks of gestation, by the time already the organogenesis has happened, and the time that we get to really titrate the dose of the thyroxine is very small. So you need to have some precautions ahead of pregnancy. Now, what are the targets in pregnancy? There is data to show that women should have a TSH of less than 2.5 before planning pregnancy, and people who are having anti-TPO positive, there is a recommendations not very strong to consider having a much lesser TSH levels in pregnancy, because if you have TSH with anti-TPO positive, you have a higher risk of progression in pregnancy, and it's preferable that you have a much tighter target in this women, but generally 2.5 is the accepted cutoff. This is just some data to show you that beyond a level of around 2, you have an increased, non-linear increase in terms of the complication risk in terms of preterm, small for gestational, birth defects, etc. Now, what happens to thyroxine dose requirements in pregnancy? Again, I think I'm running short of time. So, you can see the TSH which goes up in pregnancy, and the median time at which the TSH becomes the peak is around 8 weeks of gestation, and 10 weeks of gestation you have almost a 30% average increase in TSH of T4 which is required, and by 20 weeks of gestation you have almost a 50% increase in thyroxine dosage which is required. So basically you anticipate this, that is what you should be doing. So how do you anticipate and take an action? You consider increasing around 30% of dose as soon as pregnancy is confirmed, and this can be done by doubling the dose of thyroxine by 2 days in a week. That means if you are taking 100 microgram every day, you can tell the patient that on Saturday and Sunday you may make it 200 microgram till you come and meet me with a thyroid function test. So consider doing an early thyroid function test at least 2 to 3 weeks after a missed period for dose modification, and if the person is already on oral T3, consider converting it to an equivalent dose of T4 during pregnancy. There is no specific real dose conversions which is very physiological, but approximate is like 10 microgram, 50 micro of T3 is 50 microgram of T4. So this should be again addressed because a lot of people now get started on oral T3 for some reason or another, and you need to be aware of this. Targets again, first trimester less than 2.5, less than 3 in second and third trimester. Again, data to show you that as TSH increases, there is an increased bad outcomes in terms of preterm, small for gestational age, birth defects and perinatal infant death. And this is a continuum of increase in risk, and you can see that once the TSH is more than 10, the risk goes up significantly. Thyroid autoimmunity with normal TSH. Again, you would see a lot of people undergoing anti-TPO antibodies as a part of some general health checkup. So we don't know what to do with them. They will come with anti-TPO antibody prior to pregnancy and ask you, what should I do with that? Not very strong data. Some data to say that people with TSH normal and TPO positive is at high risk of increase in TSH during first trimester. But then there is again more prospectively followed up data to show that really may not be true. A small percentage of patients may have an increase in TSH during pregnancy. And there is no evidence to support that if you treat someone with TPO, just TPO positive and TSH normal in pregnancy, that you produce any great improvements in outcome. So deal with it, but definitely you need to check TSH in pregnancy, especially if you have an anti-TPO positive. Now comes hyperthyroidism in pregnancy. So hyperthyroidism in pregnancy, again, various adverse consequences of hyperthyroidism in pregnancy like spontaneous abortions, premature labor, low birth weight, etc. And for the mother in terms of thyroid storm, heart failure, preeclampsia, etc. Coming to a case just to highlight, 26-year-old lady diagnosed to have hyperthyroidism 4 months prior, ophthalmopathy, initial thyroid functions are frankly thyrotoxic, started on carbimazole 30 milligram per day. 4 months later she is now feeling fine. You can see the thyroid function test, the T3 is 160, T4 is 1.2 and TSH is 0.002, and she is on carbimazole 20 milligram per day. So what preconception advice would you give to this particular lady? So basically the general principles are that the natural history of Graves' disease in pregnancy is to exacerbate in the first trimester and then go into a sort of remission in the latter half of gestation. General principle is that it is always safer to achieve a permanent euthyroidism before a planned pregnancy, whether it's a remission with an antithyroid drugs, surgery or radioactive iodine therapy. And women with higher dose of antithyroid drugs should adopt a method of permanent cure before going for pregnancy. There is no safe dose of antithyroid drugs which you can consider really safe in pregnancy. That is the reason. Women who receive radioactive iodine should wait for at least 6 months to 1 year prior to conception and should be euthyroid. Again, for people who undergone surgery, should at least wait for 3 months, become euthyroid and then go for pregnancy. And in women who are treated with radioactive iodine should have anti-TS receptor antibodies checked early in pregnancy to guide prognosis. Consideration of PTU versus methimazole should be discussed with the patient. I am just going through very broad guidelines because hyperthyroidism I feel is a very specialized topic. So what will you do further for this particular patient who is already sort of euthyroid on antithyroid drugs, feeling okay, planning to get conceived? So one is that I will allow her to go for pregnancy, I will change PTU because I have been taught that PTU is better than MMI or carbimazole, or I will ask her to undergo radioactive iodine therapy and then plan pregnancy after 6 months after she is euthyroid, or I will ask her to undergo surgery and then plan thing, or I will permit surgery once the TSH becomes normal. So what is your choice? All these things look as very reasonable choices for this particular patient, but I would strongly ask you to refer to your endocrinologist because there are many in town, I think here, Sudeep is standing there. So because this is more complicated than it looks in terms of both preconception and conception management. Thank you.
Thank you, Dr. Mathew, for excellent presentation.